opposed to a comparative effectiveness of having these interventions all compared because I don't see the point. I think that the original trials and the additional analyses can point the way to your latter point. And that is if we take a look at their characteristics and what their goals are, that we can begin to match what and when. And we've already said collectively that the caregiving family community is very, very diverse, and one size will never, ever fit every person. And so that we really need a broad array of evidence that is available. That does pose a lot of challenges because, you know, can every single agency be trained in every single intervention posed here? You know, so how, I think that there are challenges to that, but I honestly don't think there's value in I think the head-to-head is some of the other medicalized, you know, or pharmacologic approaches possibly in terms of, you know, their impact for families and people with dementia. These interventions have many impacts on people with dementia that are very, very important that, that would go head-to-head with any pharmacologic, better than any pharmacological trial.
Well, but Laura, I have to differ with you because I agree with you that all these interventions have value and that if we were going to make a public policy statement, we would say that. But I would like to know if a family came to me, that particular family, what would benefit them the most right now? And if we were not to say a head-to-head trial to say, yeah, I'm better than you, but rather to say, given this profile, we've looked and we've seen that given this profile, this intervention will be better for this family.
But I just think that's an entirely different research question than a
Yes.
comparative effectiveness
I
question.
totally agree.
So
yes.
I'm not disagreeing with you. And I think that we also have some of that data in our data set
Probably.
to begin to
Yes.
answer that
Yes.
question. And
Yes.
maybe we need monies for secondary analyses to
Yes.
exploit
Yes.
these data sets. You know, whether we have 1,200 people in Reach 1 and we have 600 in Reach 2 and you have X number and then, you know, so I think that we can begin to answer those questions, but we need the funding then to do that from a different perspective. So that's
Yes.
just what I would, so we do agree.
Yes. Mike is back here right now? Yes, there you are.
I just have to say that I think it's great news that we have so many different interventions. I would hate to see people matched and saying only this works for you, because care is a changing dynamic and what families need at one point. There are two elephants in this room that Mary and Laura brought up that are not being talked about enough. One of them is multi-morbidity. The fact that people with Alzheimer's are usually older and they have multiple frailties, and a lot of these things we've said can't work for people who can't hear or can't see or have other chronic illnesses. The other thing that we're seeing, in addition to the adult-child stuff that's been mentioned, the working adult child issue of how do you meet with a working adult child without jeopardizing their job. And the other thing is that Alzheimer's may not be the most important thing for that family at that point in time.
Right.
That doesn't mean at some point in time they may not benefit from all of these different interventions. So I don't think we want to throw anything out. I think we want to say we have a menu and it works. And what we have to do is get better at selecting the right one at the right time for that specific family, and then making sure it's more available than it is currently.
Yeah, I want to weigh in against the head-to-head trial too, of the existing interventions, but I do think what is needed is if we could move the discussion up a level in terms of what are the common components across these successful interventions, and then do a head-to-head trial against those common components. Because it would be, if we did a head-to-head trial now, it would be much like doing a head-to-head trial against two SSRIs. Correct me if I get too out of place here. But it's too close. They're too close to each other. And a head-to-head trial doesn't tell you very much. But if we could rather look at two different approaches to treating the same thing, so an SSRI versus, help me, Mark, a tricyclic. Thank you. You always have to have a good psychiatry friend. That I think would advance us and start to look at what then do the different populations need. Then you can start to look at categories of intervention by ethnicity, by specific needs.
And I'm wondering, I was talking earlier about sort of our gateway program, that the meetup, our gateway program, but I'm wondering, if in a medical setting, one concern I see is just how do people get access to these programs? And do we need to have some sort of gateway program that's like maybe differentiated by stage, that's some kind of introduction to your disease or whatever by stage, and perhaps can we pull out some of the primary risks or concerns that we hear from families? I mean, we've been doing this a long time. It's not, it's pretty clear to me what the primary things, at least themes, that come up in early stage or middle stage or later stage. And as people are diagnosed, especially if we get really good at getting people to diagnose, can people be referred into this type of introductory program that's 5 sessions or 2 sessions or 3, the magic 3 sessions, and then from there they're sort of routed to more specific, or as we get more knowledgeable about who benefits from what kind of programming, it gives you 3 sessions to kind of ground people in something, and it's kind of required reading, if you will, and then you get a chance to kind of do a better assessment and then refer people, say, okay, so step 2 for you is this. And I don't know, maybe I feel like, we need people. You can't tell somebody you have Alzheimer's disease and, see you later. I mean, which is this is what happens every day. And in the medical system, I just feel like there needs to be, you have Alzheimer's disease, I'm going to give you, if you're lucky, I'm going to give you some kind of prescription, but then you're also going to go to scheduling and you're going to get into this intro to whatever based on your stage or what have you. And then from there, people are routed.
Well, I mean, I think, again, you're talking about a dementia care, a standard for dementia care, and I think that that's very important. I do think that the reach to risk appraisal concept can contribute to this discussion, and it really was geared towards moderate, severe, so I think, it's not the end all. I mean, but the whole concept of looking at the areas of risk and then providing, protocols to address those risk areas, and the amount of intensity or dose was guided by the risk concept.
I hate for that not to include the person with the disease.
Yes.
I love the caregivers, yes, but I just see sometimes that's
Sure.
kind of missing.
Yeah. Yeah, I'd like to make one comment, which is that I think that we conceptualize Alzheimer's disease as a medical illness, and so we want to treat it medically, but in fact it's more than a medical illness, as most illnesses are, and there are the other aspects that require much more comprehensive care than I mean, there are very few examples, but I remember when I had strep throat and 2 pills and I was better, and that's the sort of opposite extreme of Alzheimer's disease, which is not an individual disease, but a family disease that requires a much more comprehensive, non-medical as well as medical approach to care.
Jean.
So it occurs to me as I'm listening that I think Laura started off by, I'm pretty sure it was you, making the point about how we need a standard of care for dementia. And so when you think about this, it's a standard of care for the person with dementia and their care and the caregiver, both of whom have medical and social complications of the illness, and that varies by stage. Of course, I'm stating the obvious, but I'm trying to bring it all together. That varies over the course of the illness, and that what we really need is a menu of known interventions, which we have now here. We've talked about a lot of them. We'll talk about more in the care transition session. But maybe some kind, and the fact is that there are a lot of people now that have the dementia and their caregivers who can't wait for us to have yet another trial to say, oh, you need to add component F to A, B, C, D, and E, and you'll get a slightly better somewhat clinically significant outcome. So some kind of consensus. I mean, when I was at the Alzheimer's Association, we did a consensus building process around what was good dementia care and assisted living in nursing homes, took the evidence base, brought together experts, and then made recommendations for the people that were living in those situations now. Those were done a number of years ago. Things need to evolve, but I could see, and this is just me talking, not the federal government, but it seems to me something similar for people in the community led, what do we know now? How can we apply it to the people that are in the situation now? It seems to me sort of what I've heard, that's bringing it all together, that's kind of what I've heard a theme. That was a big speech, I'm sorry. I don't know if there's anybody in the audience or on the panel that would care to comment on that kind of process or utility.
Now, I would just comment, channeling my colleague Sherry Ling, who had to leave early. She had made the comment that not only could you looking at what can be standardized in care, but if there were standardized outcomes, there would be potentially an opportunity to compare non-pharmacological interventions to pharmacological interventions, which is the standard that agencies such as CMS use for deciding about compensation for care. And that would be something that could potentially be looked at by third-party payers, by state agencies, et cetera, et cetera. So there's a potential opportunity there. There are things that are already ongoing with the Center for Medicare and Medicaid Innovations, I should say. So there's some opportunities to take advantage of the state of the science currently.
Let me just sort of make one comment and ask one question while we're waiting for the next person. We have a lot of discussion about the menu that we now have before us of interventions and that sort of thing, but I think that in the greatest part of this country, there are no evidence-based interventions available for caregivers. And so one of the issues is it's not just how we catalog, but how we can more rapidly make these proven interventions available in the Midwest and parts of the country that aren't experiencing outside of urban areas.
I have the mic, and I feel like I'm skipping back to the previous comment, even though that one was a very important one. I wanted to just make note that when we think about creating standards for dementia care, there are actually out there evidence-based guidelines for the management of dementia, and you see them in Minnesota and California and Canada, probably elsewhere. And I think that the utility of using that structure of an evidence-based guideline is that we already have in place nationwide sort of NCQA, the National Council on Quality Assurance. And so they force healthcare, they suggest that healthcare organizations adopt guidelines and then change their systems of care to be consistent with their guidelines. And so I think there's a tool out there that's available to all of us. And maybe what we need is to make one of these guidelines for Alzheimer's disease management nationwide and look at how we then move them from dissemination to implementation strategies I know the VA has done a guideline and done implementation strategies around it, but Kaiser and other health, it's a strategy for all of us, taking what's known now in evidence-based, which is a beginning, but it's a great beginning, and gives us a tool for quality improvement nationwide.
Okay, we'll take comments from the panelists on this if we have any, and then I think I'm being signaled that it's time to break for lunch, or maybe we'll take one more question. What was the signal?
Breaking for lunch.
Okay, all right. I'm not great at sign. So, any comments on the last comment?
Well, I think there was there's another elephant. Speaking of elephants, the elephant in the room is who's going to pay for all this. So I think there should be national standards of minimum quality care, and I think that requires governmental intervention on the financial side.
Totally agree, and agree, you know. I think that is the other elephant that has to be addressed to move forward with any kind of implementation of those guidelines.
And I think Kate wants to comment on that as well.
I wanted to say that I think
Thank
that
you.
your question about how are we going to get any of this rolled out, and the question about comparing or which intervention is good for which person at which time are connected. So when I envision begging or whatever, AOA doesn't mandate, but you know, trying to push this out to places where there aren't any interventions like this, I imagine the difficulty of what we have now, 8 or 10 interventions with randomized trials and translation research behind them. So they're connected, the two things. What shall we say as we ask a AAA that has nothing? What will we ask them to do?
That's a really good question.